Well, hello everybody. It's 7 o'clock on this beautiful Tuesday evening. I'm sorry to be talking to you when you could be outside in beautiful sunshine, but we have a very important topic today and some great panelists to share with you. Just before I do all the introductions and talk about what the topic is tonight, I just wanted to just tell you a little bit about the college. Things are moving. I'm delighted to say that our hotel is hoping to open again, Ten Hill Place, on July the 15th. The museum, indeed, is opening in July, which is good news. That is the plan. And in the meantime, the college, over 200 staff have been working from home, and the IT department has been absolutely superb in making that happen. And I think in reality, the numbers coming back to work in the college will be very small. It'll be a stepped progression to people coming back to the infrastructure of the college. And that may well start right at the end of August. Certainly September is going to be the earliest time that some people will be back. But it's worked so well having people working from home that working flexibly is the watchword, and that's what we want to espouse at the college and make things easy for everybody that works for us. So many of our meetings, committees will be blended into Zoom meetings or face-to-face. So there's a lot that will change about the college, but a lot for the good, I think. So that's us up to date. I just want to say that we're talking about exams tonight, and this is really, really important area. The pandemic really has presented all of us with enormous challenges, a lot of sadness, considerable stress in working lives, and really deep anxieties about the future. And it's concerning as well as interesting to appreciate that COVID-19, whilst it has affected the young much less from a disease point of view than the elderly, it is actually the economic consequences and future opportunities that is going to affect the young far more than the elderly. So the aftermath is going to affect the youngsters, and that is a concern. And it's the same in surgery and the same in medicine. It is the trainees who have been faced with derogation of training, redeployment, and disruption to their training. And it's also been disruption to their assessment. And our trainees are the future of surgery, and we must support and nurture them during these very difficult times. We as a college put our trainees right at the centre of our planning and our policy, and these webinars, many of our webinars, have really addressed the challenges of training. And we thought that looking into the end of training and in particular assessment and exams was high time. On March the 13th, the four colleges suspended all exams going forward, and there were lots of reasons for that, which I don't need to go into, but we're now looking at that recovery period, and that is what we're going to address tonight. So to that end, I'm just delighted with who we've got to talk to you tonight. We've got John Hines, who's the chair-elect of ICBSE. He is a consultant urological surgeon at UCH in London. He's been there for 20 years, and he will be speaking to us first. We have John McGregor, who probably doesn't need any introduction. He's chair of JCIE, consultant colorectal surgeon on the west coast of Scotland. He is going to speak second. We have Liz McKinney-Bennett, who's our head of exams from the college, representing the head of exams of the intercollegiate body for MRCS. And we have Josh Burke, who's president of ASiT, a trainee colorectal surgeon, and Trish Campbell, who's president of BOTA and comes from the northeast of England, probably not too far away from where I am at the moment. Nice to have you here, Trish. And Dave Riding, who needs no introduction, our chair of our trainees committee at the college and a member of council and a trainee vascular surgeon in the northwest. So that's our team. I think now I'll just introduce you, John, to share your screen and talk us through what you think is happening to the MRCS and how we're going to take things forward. Thank you.
Okay, well, thank you very much. And thank you for explaining my role. The ICBSE, the Intercollegiate Committee for Basic Surgical Examinations, is a committee that unites the 4 Royal Colleges of Surgeons. I will take over in September. I'm currently the chair of the IQA, the Quality Assurance Committee, which is a subcommittee, and that's really the governance committee. And I'm also the chair of the Intercollegiate Risk Committee, which I run really with Liz. And the last time we met, the word COVID hadn't been invented, so it doesn't appear in the Risk Committee, but nevertheless. So I'm going to talk about the MRCS. What I say about the MRCS also, you can apply to DONES by and large. Okay. So will there be an MRCS in the autumn? And the answer is yes, there will. Almost certainly in October at the published dates. Now, the reason I'm certain about that is I'm going to explain all the preparatory work that we have done. There's currently a planning committee, and we meet every week, and there are 3 clinical leads. There's Frank Smith, who's the current chair of ICBSE, Carl Trimble, and he chairs the OSCE group, so it's his examination, and then there's me in my position. We also have the ICBSE manager. We have the 4 heads of exams, including Liz, who's with us this evening, and very importantly, we have our statistician. So we meet every week. We're working with the GMC. We've had an individual meeting with the GMC, and we meet with them in a larger group. And we also work with the Academy of the Medical Royal Colleges, because we're all in the same boat. We're all faced with the same problems. The physicians, the obstetricians, we all have the same problems, and the problem sharing has been very useful. And interestingly, we're all coming up with the same ideas. And the other thing that's happened quite recently is the OSCE subgroup have ratified the potential formats now for the next examination, which we're considering in an options appraisal. So where we've got to is, so for a start, the GMC know exactly what we're doing. Everything we do has to go to the GMC and be approved, which is a very important safety measure for making sure we do the right thing. And we're up to speed. We speak to them all the time. So in fact, tomorrow we've got to the point where we're going to, I hope, complete our options appraisal of what the examination will actually look like. Now, we'd really like to deliver a 17-question face-to-face examination, possibly with some social distancing. We've recently gone down from 18 to 17 questions. That was planned. But our optimum would be to deliver a 17-question face-to-face examination. And you can imagine there might not be real patients there. It's not giving any secrets away to say that there will be suturing. There's suturing in every exam, and you don't need a real person there to demonstrate that you can suture. Of course, it might not be possible to deliver that kind of examination, and if we go into a more stringent lockdown than we've got now, we might have to have a completely different examination. So we're also considering there's a variety of formats, but essentially having fewer questions delivered remotely. That would be what we'd hope wouldn't happen, but we would rather do that than have to abandon the examination all in all. And then we're considering some hybrid options as well. And we would still hope that with a hybrid option that we would deliver 17 questions. All of the options have been analysed statistically, and most importantly, whatever option we have, we are very reliably told that the question reliability, which is the quality of the examination, is maintained. And so we're happy that whatever the format of the MRCS is, it will be a real examination. It will be as valid as every other MRCS. And it's going to be a real test of the curriculum, which is what we expect everyone is working towards. We've worked out a few more things. So obviously we didn't have an examination in May, and we do know that we can accommodate all the CTs in the country who need to take this MRCS for career progression. So that's already worked out. We can accommodate a lot more people than that as well. But there should be no concern that CTs who have to pass the exam to move on, they can be accommodated. We are aiming at October, but we're being flexible. It might have to be December if that is necessary. We can do that. And of course, we're bearing in mind the impact that would have on the schedule for next year. And we're still planning next year, February, May and October. But if we do have to have an examination in December, that might change a bit, but that is in our minds. So where we are is we're doing the options appraisal tomorrow. And then next week on the 2nd of July, my committee, the Quality Assurance, the Governance Committee, will go through everything with a fine-tooth comb. These meetings last 6 or 7 hours normally. This will probably last longer to make sure everything is as good as it should be and quality assured. And the day after that, we have the Intercollegiate Board Committee, which will again ratify everything. And then the GMC would expect us to make a submission, which we will do. And we're working towards actually the dates that are set for the deadline for applications for candidates is in July, so we're expecting that to hold. And also we're expecting the exam schedule to be finalised so we can tell all the candidates what the examination will be like in August. And again, the IQA will be, as well as scrutinise everything before, everything after the examination will be scrutinised. So that's where we are. And then lastly, there will be an intercollegiate examination part A in the autumn. On the dates that are planned, it might run over 2 days instead of one. And it could probably will be at an examination venue with some social distancing, but it might be delivered remotely. We're working on that. And again, if it has to be delivered remotely, the GMC will have to give approval for that. But the examination will be the same number of questions, the same type of questions, and so quality assurance is not affected. So that's all I have to say, and thank you very much for your time.
Great, thank you, John. That was very clear in terms of timeframes and what your plans are. Clearly, there are still some questions to be answered, but they should be answered fairly soon. And with, of course, the recent lifting of the social distancing from 2 meters, or the potential lifting of that is going to make things a little bit easier. I think we'll just go straight on to you, John McGregor, to talk about the exit exam, the JCIE, for all the specialties. So over to you, John.
Okay, Mike, thank you. And I hope the screen has started sharing appropriately. There's going to be a bit of overlap with my namesake, John's presentation. JCIE is an intercollegiate. Perhaps the slight difference from ICBSE is that JCIE is responsible for all aspects of Intercollegiate Specialty Board or FRCS exams, whereas ICBSE quality assure, develop and maintain the exam. JCIE also delivers, whereas the MRCS is delivered on a collegiate basis. We've talked already about, and the President mentioned it in the introduction, the statement on the 13th of March that really stopped everything in its tracks with effect from the 16th. And really the implications for JCIE were, just to fill in a bit of the background for those that might not be fully aware, Section 1 is a computer-based testing exam that's been held for the past 10 years in Pearson View Centres. Entry point for most candidates is at ST7. It's dependent on ARC-P outcome 1 at ST6. It's a year earlier in urology and max fac simply because of shorter training schemes. What happened with Section 1 is all 10 specialties had a diet scheduled for June and July, and hence these were postponed and that amounted to 496 candidates that didn't sit the exam that they were entered to. As per the timetable, the next exams are scheduled for November of this year. Section 2 is for the majority of specialties, both oral and clinical examinations, all scenario-based in the level of higher order thinking. You can't enter it unless you've passed Section 1. Not all specialties were impacted by these spring cancellations or postponements, because we had 3 specialties just had a diet in the penultimate week, really, of examining. But the ones that were affected, it was 450 candidates that were postponed. And our next series were scheduled to start in September, a big one, general surgery, in the first week. Now, if I move to the recovery plan, Section 1 is relatively straightforward in that we are planning to recommence as per the published timetable. 5 specialties in November, 5 specialties in January, with the closing dates unaltered from as they have appeared on the JCIE website from when they were launched. We've been engaging with Pearson VUE throughout, and they have been extremely helpful. They are modifying their delivery to allow for social distancing, and that is 2-metre social distancing, not any revisions that are in the process of being announced. And their capacity indications that Pearson VUE are giving us are very encouraging, such that our intention is to accommodate all candidates displaced from these June-July diets, plus trainees who will become eligible this summer, courtesy of ARC-P career progression. Now, it's important also to point out at this stage, while I said earlier that an ARC-P outcome 1 is the normal entry point at the appropriate level of training, a 10.1 will not preclude entry. As everyone is aware, a 10.1 is a no-fault ARC-P outcome, simply because the training opportunities were not there for the workplace assessments that would have taken place. So that you can enter with a 10.1. Section 2, however, a little bit more problematic. It takes a lot of planning. It moves around the country, that's the UK and Ireland. And we were sitting in the early stages looking forward, because we have to plan many months in advance with the unpredictable course of the pandemic. What would be the status of gatherings? Would we be allowed to travel? Could we get facilities, hotels, let alone clinical facilities for the clinical components? What about examiner availability if surgeons have not had a lot to do in clinical terms in recent months, but they are going to be in demand to recover the service as we get going again? And also there's the question of patient volunteers. Now, having cancelled a neurosurgical exam at about 4 days' notice, I really was very much of the opinion I didn't want to keep trainees dragging along, preparing for an exam that may or may not happen in September. Really took the decision early, supported by the college presidents, that September was just far too early. So we were not going to run in September, and we would base a recovery plan on a more realistic time scale later in the year, which is November, and perhaps running into the first week of December. So essentially, we have worked up at JCIE 3 scenarios, and rather like John saying that he really wants to deliver a face-to-face OSCE in October, we want to deliver the best case scenario, which is to accommodate all candidates that were displaced from the Section 2 diets in the spring, but also those that were scheduled to enter in the latter part of the year. We have sort of a middle ground scenario where we have to focus down on the purpose of the exam, part of the assessment blueprint for CCT, in which case the middle ground scenario would be focusing on trainees due to certify within the next calendar year. The worst case scenario, which I'll talk a little bit more about, would be we're in a draconian lockdown or emerging from a second one, and we might have to restrict delivery to trainees due to certify this year. Staging, we have a clinical component now. The staging for the best case scenario is based on using Nightingale hospitals. Everyone knows these Nightingale hospitals are sprung up around the country. The majority of them have had either no patients or very, very few. In fact, that's all of them have either no patients or very, very few, fortunately. The pictures here just happen to be the Scottish one, which is called the NHS Louisa Jordan. It's based in the Scottish Exhibition and Conference Centre in Glasgow. I have a sort of certain amount of input there because I've been part of the lead medical team that was involved in putting it together. And unlike the English Nightingale hospitals, this is a direct arm of Scottish Government. It's not run by a trust or a health board, and the Scottish Government are very receptive to training and uses of the place as it is mothballed from a clinical purpose. Other advantages, it's got a huge adjacent hotel with probably the biggest ballroom I've seen for social distancing of oral exams, and lots of other nearby hotels for a variety of budgets. And it might be at one end of the UK, but transport links into Glasgow are reasonable. So the best case scenario is very much based on using this, and we're getting very encouraging and supportive noises from the Scottish Government. These are the candidate numbers which I would need to deliver and which I hope to deliver. There were 450 candidates, as I mentioned earlier, in the left-hand column there, who were scheduled to sit in the spring. The not applicables are the 3 specialties that had exams in early March. Autumn ones, obviously, there were relatively few candidates already entered because the Section 1 feeder were cancelled in June and July. The specialty total over at the far end. So best case scenario is 544 candidates. Middle ground, well, the middle ground one would come into play if we're sort of in a bit of limbo. We can't use the Louisa Jordan or any of the other Nightingale hospitals because they've been used for other purposes. Perhaps we've had a little bit of a second spike in the autumn, although I think that's looking less likely than it was. It might be the winter time. I think the current modelling's heading towards if we do get more activity. And or we might have limited examiner availability. Again, we wouldn't be going into mainstream clinical facilities. We would be basing this around colleges, and the focus would clearly be on this college, Royal College of Surgeons of Edinburgh. That's where JCIE offices are based, and there is a hotel, as the President mentioned earlier, aligned to the college, which makes staging much easier, and being, again, a major city, there's plenty of other accommodation. The middle ground numbers are there. If you add the 2 columns there, the 2 columns, the left-hand one lists those that were due to certify this year candidates. These are trainees only. I should say these are trainees only due to certify because it's part of the training programme. The second column is those for next year. So we've reduced the number from 544 to 275 total. Worst case scenario is, sadly, we're hit with a major problem in the autumn going into the winter with second or third wave of COVIDs, with limitations in gatherings, perhaps restrictions in travel. And in that case, we would have to look at remote delivery of at least part of the exam. We think this is relatively straightforward to do with the orals for the smaller numbers it would involve. As for the clinical component, a few possibilities. Either delay it for a few weeks and separate the clinicals and the orals, deliver it regionally. We have examiners the length and breadth of the UK and Ireland. And by regional delivery, you cannot be examined by someone you're working with or have worked with in the past 2 years, but we have big examiner banks, and it might mean, somebody from Glasgow going to Edinburgh to sit an exam, regional travel rather than everyone congregating together. Obviously, there's the fallback position of remote delivery. We're already talking to the GMC and John, Hines and myself, and all other colleges get together with the academy groups for these sort of things. So that's very much the worst case scenario. And it's down to only 48 candidates there. These, again, are trainees who have passed Section 1, who are eligible and waiting on a Section 2 date and due to certify in 2020. So not a huge number of candidates. Certainly very keen that we do deliver the maximum. It minimises delay for everyone. If we can do everyone on all candidates, there's equity of access, whether you be in a training programme or not. Obviously for career progression, and from our point of view, it clears the backlog. Because quite simply, if you don't get everyone through and you're on Section 1 diets in the autumn, you're going to get a domino effect and have an even bigger number into February next year, when the Nightingale hospitals will likely have gone if COVID is not emerging again, and we'll be back to having to use mainstream clinical facilities in the midst of winter pressures, which is always difficult. The downside of the big one is it does rely on Nightingale hospitals' examiner numbers. That doesn't seem to be a problem. We've gone out to our examiner banks and they are volunteering. Willingness of volunteer patients we've got to think about, and there are options of using substitute patients, perhaps some modelling or whatever, and these are things, again, that possibilities that wouldn't fundamentally change the assessment. It's more tweaking of the delivery. And I should say that in terms of the JCIE ASiT target, puts a build on them to try and deliver, I think, exams for 544 candidates in a month, but they're up for it. It's the bottom line. Now, going forwards, that's obviously for this year, and moving into the next part, the bit of next year. I think everyone's aware now that the GMC have approved outcomes-based curricula for all 10 surgical specialties, which will be implemented in the autumn, in August of next year. Now, we feel that's an opportune moment, also because one of the other things that you may or may not be aware about, we have revised the Intercollegiate Specialty Board exam entry criteria for not in training candidates to really, as closely as possible, align them to what a trainee does to do. That's not to make entry more difficult. It's all about preparing candidates for the assessment. And so our plan now is to move to a revised Section 2 format to parallel these changes, very much aligned to the new curricula and complementing the new workplace-based assessments, including the MCR that will come into play. So we have a short-line working group for Section 2 development in place that's currently reviewing the performance of existing Section 2 examinations, identifying best practice, all the elements that make up the utility of an examination. The short-line working group determining a framework for examining delivery, what's the optimal staging environment, and we'll certainly take this out of mainstream clinical facilities, which, quite apart from COVID, we're getting more difficult to rely on. And we will look at access options. There's been quite a change in the travel scene, not again just because of COVID, but with the airlines like Flybe going out of business, does make access to certain corners of the UK difficult and expensive for everyone, and we need to bear that in mind. And we want to reduce, not negate, patient involvement. I've done quite a lot of work with our psychometrics team, actually showing that the clinical examination, the clinical component is probably a more discriminatory, not probably, is a more discriminatory component in many of our exams, particularly long cases than orals. And we're looking for a bit more harmonisation across the 10 specialties in terms of marking episodes. Everyone knows that the more marking episodes you have, the increase, the more you impact, positive impact you put in reliability. So what we're certainly not aiming to do with the new exam development is throw this little chap on the right-hand side out with the water. We certainly don't want to dumb down the examination. We believe that the ISB exams are a different level from the European boards, etc. We really do not want to move permanently to remote delivery. I, for one, would certainly be dead against that. I think there's a lot you cannot assess by remote delivery before you get to the security and technology aspects. You know, there's non-verbal communication, and there will be recruitment and retention of good examiners. And we do not, for the reasons I already mentioned, want to lose completely the assessment of clinical skills. Timeline for the new development, short life working group I chaired last week. ISB is already working, and there's input from colleges, trainees, specialty associations and the SACs. Short life working group will meet again at the beginning of August, feed to JCIE in September, so that we will have this plan to the GMC by the autumn, and at the same time as it goes to the Joint Surgical Colleges meeting, which is the presidents and the chief executives. And we aim to introduce this hopefully late next year. We can never tell the delays that you might get when you go to the GMC, but I would hope that it would be next year. So to summarise, for this year, Section 1, all being well, will proceed as per the published timetable. We will deliver the same examination format for all candidates currently entered in Section 2. Candidates expect that. GMC will look for the same robustness of any assessment, and patients and public expect that. But we are working on a new exam development for introduction late next year with the appropriate advanced candidate notice that will not require mainstream clinical facilities, will reduce but not necessarily negate patient requirement, aligned to the new curricula, but most importantly with maintenance of standards and the focus being patient safety. Thank you.
John, that was tour de force. Thank you very much to both you and the other John I thought that was incredibly clear. There are still questions that I'm sure that many trainees will be worried about, but some of those questions may not be answered yet, but hopefully it will be soon, because it's dependent on the pandemic and how things pan out. So I think before we go any further, I would like to bring in initially the trainees. And Josh first, would you like to, is there anything that you would like to ask the two Johns that you're not quite clear about on behalf of your of ASiT?
Yeah, thank you very much for both the talks. It's a question to both speakers, if that's all right. I think we spoke about it a bit in the past, but one of the concerns amongst trainees is that obviously to prepare for an exam often takes multiple months, up to years, and there is concern that if there's a derogation from the norm, that might unfairly disadvantage a trainee, independent of the times that we're in. Given that the proposal is going into the GMC, will they sign off the three options in terms of best case, intermediate, worst case scenario in advance, such that if the current crisis changes, we can switch to it quickly? Or will you have to go back to the GMC with an alternative if we come across a stumbling block?
John, do you want to go first, or will I take that first, since it mentioned best, middle and worst for me?
Yeah, I think you go for it, John, first. Yeah. McGregor.
I think, Josh, we do not need to go to the GMC with the best and the middle scenario, because the assessment will be the same. It'll be a tweaking of delivery in terms of using a Nightingale hospital rather than a mainstream clinical facility, or using a conference or college hall rather than that. Tweaking of slightly, maybe with a patient substitute, maybe part of our lay advisory boards, these sort of things. But it's not the middle. The best and middle do not require any GMC involvement. They know about our plans. The worst case scenario, if we have to deliver remotely, yes, we've already started discussions with the GMC through the Academy. GMC are, however, assuring us that they will approve changes very quickly. And your point about preparation of exams is very well made, which is why I, in conjunction with college presidents, made the decision in April that we were not going to start Section 2 in September. That was just unrealistic to have people preparing and then pull the rug from below their feet.
Thanks, John. John Hines, would you like to say anything to that?
Only that I agree with everything that John said, and I do think carry on preparing the way that you would normally prepare. The examination might be delivered differently, but there's still going to be examinations on the same curricula. And I think our plan is always going to be that if the delivery method has to change, we will still be able to ask the same type of questions on the same topics and subjects. And that is what the scrutiny internally from the colleges at the IQA and then the GMC will assure. And the statisticians have assured us about the reliability of the exam. So I think just get on and prepare as you normally would.
Thanks, John. There's been a few questions about exactly that, and one came in saying that his consultant had advised him not to take the first Section 1 of the JCIE because he wouldn't be able to do the Section 2 for about two and a half years because of the backlog. I don't know what he knows, but that's not what we know. So I said to him, just if you're ready to take it, you should take it. And so a lot of misinformation out there. So Trish, any questions for the...
We'll just to seek a bit of clarification with regards to priority. So I know, John Hines, you mentioned for MRCS, you've got slots available for all those CT2s that kind of need it for progression. But then what happens after that? Does it then go to CT1s, then to FY2s, or does it not really matter? How does that work?
We haven't discussed that in great length, but we wanted to make sure we could certainly offer places to CT2s who need it for career progression. In fact, there aren't that many of them, and I don't really foresee there being a big problem. I think we can probably accommodate most people. We'd need to see who applies, which we'll know in less than a month from now. But I'm really hopeful that we will probably be able to offer the examination more or less to everyone who applies to sit it in UK and Ireland.
Brilliant, thank you.
Liz, do you want to come in?
Yes, I would just say though, please make sure that if you do want to sit for the October exam, you need to apply, because it's the only way that we can see that you want to sit the exam, obviously, and then be able to look at what the priorities are going to be. So if you haven't applied yet for it, please do, and then we can sort out the accommodations from there on.
Good. Just bring Dave in. Dave, is there a question before I bring you in, Josh? Yeah.
Yeah, I have a couple of questions actually. With regard to the people who've already entered Part A, will they be obliged to take the next diet of the exam, or will they have the flexibility to move it further backwards if they feel the circumstances don't allow them to do the work according to the new calendar? And a question for Liz as well. We've had quite a lot of questions about the international versions of the exams and whether they'll still be running. So 2 separate questions there. So
Liz, do you want to take those? I think you could answer both probably. Yes,
absolutely. In terms of people who've sat their Part A and want to move on to Part B, there should be no compulsion. I think the only compulsion for anybody needing to sit the Part B OSCE will be those who are under pressure really to come out of those training posts and to move on to ST3. So if you're one of those cohort, then please make sure that your application's in and you make it clear to us as well. In terms of the overseas or the international candidates, truth be told, I think it is highly unlikely that we will be running any exams overseas for the MRCS Part B OSCE this year. However, we haven't cancelled anything, we haven't even postponed anything yet, and we've left those applications open because, as we all know, things are moving and changing on a very sort of rapid basis, and we don't want to make big decisions that could have adverse effects on people's careers across the world, because we absolutely value our international candidates. So everything we can do, we will do to support those applications. As soon as we can, we will go. But at the moment, the Foreign Office is still preventing what they class as all but essential travel, which for us means that we're not covered. We're not allowed to travel overseas. We can't send examiners or assessors or staff. When that changes, we will then be trying our very, very hardest to reinstate those exams.
Thanks, Liz. Sorry, we've got to be absolutely clear about it, that we're in the hands of the pandemic here, and whether you can fly out there, quarantine rules and everything else. And remember that the international MRCS is exactly the same exam. It's an intercollegiate MRCS, and it has to be done to the same standard, same quality assurance, and exactly the same exam as it is domestically. And we can't run any kind of dumbed down or remote exam if we're not running it domestically. So I think that's the problem that we face, but we will deal with this for our international. We have not forgotten about the importance of our international candidates, and we will be keeping them up to date on a regular basis.
Yeah.
And I want to just thank fantastic panelists who are answering questions like nothing on earth. It shows that they can multitask, talk and answer questions. All of you have been brilliant. 25 questions answered already. We've had 43 in, and really quite important questions coming in. A lot coming from internationally, but there is one question. Neurosurgery doesn't have core surgical trainees as it is a run-through specialty. Will our trainees be given the same priority as core surgical trainees? Do you answer that one, John?
Yes, and I have answered that one, and the answer is yes.
Right, good, thank you.
Can I just say one thing with reference to the last question, in fact?
What?
I think one of the points might have been, if someone has applied to take Part A in April and clearly didn't take it, do they have to take it at the next sitting? And the answer is no.
Right. Yeah. Thank you, John.
So, Mike, can I just say something about the international FRCS exam? Because there are a number of questions, and it's difficult to type back to everyone at one time. A lot of questions and anxieties when we'll be holding the Joint Surgical Colleges Fellowship exam. The Section 1s are advertised for the autumn. Section 2 poses exactly the same difficulties as Liz McKinney-Bennett was talking about there. And added to that, there are also country-enforced restrictions on gatherings, and that applies to Malaysia, where we hold. So at the moment, I'm afraid I cannot give any guaranteed plan as to when the Section 2 JSCFEs will take place. We are aware of it. I was meant to be in KL this week doing exactly that with a T&O exam, and for the very same reasons, the unpredictability, we cannot give a definite date at the present time.
Great, thank you. Okay, any other questions from Josh and Trish and Dave for the panelists? Josh?
Sorry to put you both on the spot, but I have to ask it. If we have to derogate from the norm and go for worst case scenario, you're a trainee, you've had a terrible time during the pandemic, you've been informed that the exam is going to take place but in a slightly different format. Has there been any discussion with either committees in terms of whether that would affect the number of attempts that a candidate's allowed? Would this count as part of their normal quota, or has there been a discussion in terms of potentially adding an addition on to that?
John McGregor, do you want to come in on that? I think it's going to affect you more.
Yeah, it has been discussed at Academy, Josh. There's no definite decision is made on that, because you've got to be careful you discriminate one way, both ways. That if you give someone an extra attempt, how does that affect people who sat the previous diet? So, I think it is something that further discussion is required on. Certainly on one of the other criteria for exams, the 7-year rule that you have for completion, we have stopped the clock whilst the postponement of exams is in place. But certainly the point you're making about the number of attempts is something that we need to look at very closely and accept that, and is part of ongoing discussion.
So, John, there's another question coming in. In fact, there's a few saying, when will the decision actually about which scenario, best, middle, and worst case, is going to actually happen?
I was just starting to type a reply to one question there on that. I wrote to all candidates in the system. Can't remember exactly when it was. It was sometime fairly early in May, probably late April, when we were saying that we weren't going to run in September, and said we would update in July. I know the Scottish Government are having their executive group meeting later this week, when we're hoping to get the decision about the Louisa Jordan from. I'm hoping that will be positive. If we get that positive decision, we've already gone to examiners. We have sufficient examiner availability to run the best case scenario. Clearly then, and the only spanner in the works will be a further wave of COVID. So July, we promised we would update everyone, and I intend to do exactly as we said we'd do and update you then.
Dave, you want to come in?
Yeah, it was just one of the features, I guess, of the pandemic response has been how the devolved nations have had different regulations and different stipulations about what people can and can't do at different times. I just wonder whether it would be more sensible to consider having a nation-by-nation approach rather than perhaps asking people to travel to one of the countries, particularly Scotland, which has different rules and regulations. I just wondered if there's a contingency in place to avoid any chaos emerging from that kind of scenario.
That's a difficult one. John, do you want to come in on that? I doubt whether you've discussed this in detail.
Which John? Me?
John McGregor.
We haven't discussed it in detail. I have made provisional inquiries about one of the other Nightingale hospitals with support from the medical director and management team there. The issue is we don't want to split the exam up and hold it in multiple different places, not because of costs, because the important bit about all these exams is the standard resides in the expertise of the body of the examiners, and we go through a calibration procedure for the orals and clinicals at the start of each day, or in fact for the orals for the day before. So if you've got regional delivery, you lose that, and the reliability of the exam is not as good. Yes, there are slight differences at the moment, but if we are continuing to progress such that we can run the best case scenario, November is at least still, 4 or 5 months away. that I would hope that irrespective of whether it be in Cardiff, London or Glasgow, we should all be able to get in the one place.
And whilst we can't second guess how the pandemic is going to play out, Scotland actually and Glasgow and Edinburgh have come off less than certain parts of the big conurbations in England. And so I think that it is more likely that they are going to. Things can change, obviously, but that would be a point that I would make. There was a question, is there a plan, this might be for you, Liz, is there a plan for more MRCS OSCE preparation courses to be delivered online? I haven't managed to book a space on the July RCSEd pilot course. Please, could you let me know?
Well, I'm afraid I'll have to defer to education colleagues on that one, but we certainly want to do that. And I think the more that we can help support the candidates, the better it would be for everybody. And we absolutely, if we end up doing any type of hybrid or any type of remote delivery for the OSCE exam for October, I promise that we will be hitting the webinars and hitting certainly some of the online teaching, so that we can support the candidates if it's a different delivery format. So please don't worry, but we're doing our best to get as many of the of education and support and training things done online in the interim. But obviously, with so many staff furloughed, it is difficult for all of us. But we're doing our very best.
So Ken asks, he's a urology trainee, when will the revised timetable for the FRCS Part B exams actually be released, John?
Well, we've got most of the JCIE staff are currently on furlough, but they will be coming back in July. If we get to the stage of intimating out to everyone, as we discussed a moment or two in mid-July, that we're going ahead, we will have the timetable as soon as possible thereafter. So I can't give you an exact date, but we need to get it fixed as much for the availability of examiners, and we need to book the hotel, and we need to start recruiting volunteers. So we will do it at the soonest possible date, mid-July, perhaps drifting a couple of weeks later, but certainly it will not be you being told in October that you're sitting an exam in November.
So you've just answered really Alistair's, who's an orthopaedic trainee, who's asking about the FRCS also in November. Well, and so you've just answered that. So there are a lot of these questions coming in really about...
A quick question.
Yes, Trish, sorry.
So for the FRCS Orth, we rely quite heavily on patients for the examinations. Have you had any sense of whether or not you'll have those patient volunteers? Because I'm imagining there's a whole cohort of patients probably scared to come and to be examined.
Yeah, we haven't actively gone and started recruiting the patients yet, Tricia, until we know which scenario we're going with. But I think we accept that, I mean, your point is very, very well made. There's a sort of certain hope that if we're not in a mainstream hospital, it might reduce anxiety. We will apply all PPE measures that are currently in place in the workplace. So if you're at work with a mask on, you'll be at the exam with a mask on, an apron and gloves on. Just as it is the NHS dress code, we expect that, and in exams we would expect whatever PPE. And as I think I did mention, we may have to use patient substitutes, whether they're other volunteers or whatever, that we can scenario-based with skilled examiners to talk through things. It's all about the tweaking of delivery rather than a fundamental change to the assessment.
And I think that's the key thing, that not a change to the fundamental assessment, but little tweaks that make it easier and safer. Because after all, our responsibility, or the two John's responsibility, is to the candidates and to the staff and to the patients who might be volunteering. And it has to be safe, and safety is number one. And that is what the Joint Surgical College, the 4 college presidents, have tasked both the two Johns in delivering. And they've worked really hard to look at all the scenarios. And I think the emphasis should be on, we are hoping for the best, but we have to prepare for the worst case scenario. And that is looking unlikely at the moment, but who can tell? Anyone else want to come in?
Can I just go back to something,
Yes,
President?
sure.
Is that all right? Yeah. So, with regard to candidates who fail, whatever happens for us in October, will they be limited to the same number of times of taking the examination? We have discussed that quite a lot, and I think we'll be fairly. Is the word lenient? I don't know, but I think a lot of that depends on the scrutiny and the analysis of the outcome of the examination. Because actually, if the pass mark's about the same and if the proportion of candidates who pass is about the same, we'd be very happy we've actually held the same examination, and that might instruct us. However, if it works out differently, we'd take a different view, I think. So it might be we can't really answer that question until we've done it and tried it.
Thanks, John. And Liz, just a quick one here, straightforward. What would the policy be if a candidate recognised for an exam falls ill, one assumes with COVID, just before and has to isolate?
I think that will, once we get to the position where we can actually start to run the exams, we're going to have a whole set of regulations, and there'll obviously be there'll be special measures that will be required. So we will send out a full information package to the candidates. There may be a whole plethora of things that we don't normally do, but we will address all those as part of our analysis project. So we will have a policy on people who are who fall ill just before, but that won't be any different probably from the current one, which as long as you can have a doctor's note to say that you're ill, then the standard procedure is if you can produce a doctor's note, you'll be able to get your refund for your place. If you turn up and you are declaring yourself fit to sit, so if you go through an exam but then say afterwards you were ill, that wouldn't get you a refund. So please hang on for the COVID specific regulations, but I feel pretty confident that we will have a very robust standard for that, because the last thing we want anyone to do is to come anywhere near to an exam venue if they're feeling even slightly more hot and bothered than one would expect about to go into sit in OSCE. I think that might be fair.
Okay, now John McGregor, there's been a few questions about not in training candidates, and this is a very important group. It's a big group, and they're not represented on the panel tonight, and perhaps that's my error, because they are asking, well, look, if you're prioritising the trainees, obviously, if at the end of this year, for those coming to the end of their training, how are they going to be disadvantaged by all of this, and how are you going to deal with it?
Yeah, I mean, I would reiterate that my intention is to accommodate all trainees, not be selective. That being the best case scenario is the one that we are focusing on delivering, and a lot of work going on to bring that to fruition. Sadly, if we are restricted through factors beyond our control, largely being further waves of the pandemic, such that we cannot get 544 candidates, it was around that number, through, then we need to focus on where the exam is immediately required. Now, it is inexorably linked to training. It is part of the assessment blueprint, an ISCP. It would not just be not in training candidates who would lose out if we had to restrict. It would be a lot of trainees as well who tend to sit Section 1 at the beginning of ST7 and Section 2 later on in the same training year, fully more than a year before they're due to certify. Sadly, we would need to focus on using the certification barrier. I appreciate that is unfortunate, it is difficult, but let's just hope it doesn't happen. That's why I am fully focused on encouraging my boards that we deliver the best case. And that is the case I have put to the Scottish Government as well, for the very same reason that we get use of the facility to do that.
And so, again, there's a lot of T&O, Trish, there's a lot of T&O candidates for Section 1 coming in, just applying for T&O Part 1 exam in November 2020 on JCIE. When will the final decision be made and payment taken? You've answered that, John, really. We don't quite know yet. But in terms of taking payment?
Well, because the office is closed and the senior staff are working remotely, the vast majority of staff are in furlough, we set up the system that we would not take payment from candidates, but they would be doing all other aspects of the entry process. I think the plan is to have the office back up and running again in July. And Pearson View, if they continue in the vein that they are, then I would think very soon afterwards, I'm afraid you will be being asked for payment and confirmation of the place. Because the indications from Pearson View is we will be able to accommodate all these people.
There's quite a few people asking just, can't you put on more exams? Can't you put on more sittings of the diets of the exams? And there is a lot of logistics involved in that. I think that for both Johns to answer, but I think that do you want to just mention some of them, John? Either John?
Yeah. So to run the exam normally, we normally know what's going to happen 2 years in advance. We know when the exams are going to be. The examiners roughly know when they're going to be examining. It's very, very complex. So in these difficult times, it's very difficult indeed just to put on extra examinations, and I think that's going to be quite difficult. I think our job is to make sure we hold the examinations we thought we were going to hold and do it to the very best of our ability to make sure we have really more or less the same examinations. I don't think extra ones are possible at the moment. There was just one other thing about the question that we sort of got quite close to. Someone's asked a question which really, if I can paraphrase, if they don't fancy the format of the exam, how late can they withdraw? And I think that's something we haven't really discussed yet, and that's probably much more for Liz.
Well, it's not. I think it's more for joint surgical colleges, actually, to make a decision about that, because if they don't like the new format, can they just withdraw, get their money back, and just refuse to take it? Well, the answer is that they won't get the exam. And so if that is the format of the exam that going forward, they will need to take it to progress. I think that's the answer to that, really. And that's the answer that I think joint surgical colleges will pass on to the two Johns if it were to happen.
And I think that's right, because we're anticipating the examination will be as close to what we now call the examinations as possible. And I think everyone really should anticipate, candidates should anticipate, the preparation should be the same. And we will examine in the same way. And I don't think it will be that different in actual fact. I don't think that should be too much of a concern.
We have to maintain the standards, but we also have to be compassionate and understanding for the stresses and the difficulties that our trainees have gone through over this last few months. And I think that for us in our ivory towers looking at it, we need to be very understanding of that. We're coming towards the end of our hour, and I just want to leave the last few minutes to our trainee representatives to just either sum up or ask final questions that you feel that perhaps we haven't touched on yet. So can I start with you, Dave? Any questions or any comments that you'd like to make about what you've heard tonight?
So there's been a few questions asking about whether there'll be any requirement for candidates to be tested themselves or to undergo a period of self-isolation before they conduct the exam. And I guess that also applies to examiners and any simulated patients or patients who may be taking part.
Do you want to answer that, John, or shall I answer it?
I think very briefly, David, I'll answer that, just saying we haven't made specific plans for testing, but as I alluded to already, whatever happens in the workplace will be brought into the examination processes in terms of PPE. And if we have to be tested to go to work, examiners will have to be tested to come to an exam.
I mean, there is testing, obviously, in COVID light sites for major cancer surgery already in the workplace, but there isn't enough testing available across the piece in the United Kingdom to produce all these COVID light sites yet. There was only 30,000 tests, actual antigen tests performed in England yesterday. So it is still very much a problem, testing. And so I think it would be isolation would be the recommendation if that was what the situation was in the workplace, Dave. It was a good question, though, very relevant. Josh?
Yeah, so just finally, thanks for the college for hosting this. I think it's been an excellent event, and to both Johns for including to incorporate us into the discussions on how to mitigate the effects of the pandemic. There's been a question that's come up 3 or 4 times. It's probably one for Liz, in terms of FY3 or F2 candidates who will be a trainee come August. But I think a couple are just confused in terms of their eligibility to apply in the current circumstance and how they would be prioritised as they're not currently a trainee as an applicant, if that makes sense.
Yeah, thank you. There'll be no difference as far as we're aware in terms of eligibility to sit the MRCS Part A. If you're eligible to sit, then that's fine. The priorities, we genuinely don't think we're going to struggle to accommodate everybody that applies for the Part A exam, and that's UK and internationally. So please don't worry. If you're eligible and you want to apply, please do. And bear in mind the closing date for the September diet is the 3rd of July. So please don't hang about.
Yeah, remember that. Get those applications in. Trish, your summary or questions?
Just a bit of clarification. So obviously we've got like a plan A, plan B, plan C, but for the best case, middle case, and worst case scenario, is it just a numbers issue?
Sorry, I was just typing a response to that question, Tricia. Oh, right. No, to some extent, we're going to be controlled by what we can deliver. Now, I mean, the Nightingale hospitals are perfect for socially distanced large numbers. Mm-hmm. Colleges, if it's the Edinburgh Quincentenary Hall and the Playfair, yes, it'll be smaller numbers, but there'll be tweaking of delivery if we have. And particularly with the worst case scenario where we couldn't have big groups of patients together, hence the numbers are down. And if we have to go to remote delivery, we'll be using much more scenarios, simulation, whatever, and that's why we have to go to the GMC with that. Yeah. I still reiterate that it's largely factors out with our control that will determine how many candidates that we accommodate, but the attention is the same assessment, the same robustness, so that the public, the candidates, the GMC can all be reassured you've had a fair crack of the whip.
Yeah, thank you very much.
Patient and staff safety and candidate safety and standard of the exam has to be exactly the same. John, the last comment just about delivery of the exam. Of course, a lot of the examiners, particularly in second part of FRCS, are quite, and I include myself in that, elderly, and at the time of life that they are slightly more at risk than the youngsters. And so this is a bit of a challenge as well to identify examiners for the second part. Is that something that concerns you?
No, it did initially, for exactly the reasons you mentioned, Mike, but the board chairs have already gone at my request to their examiner pools. We've had 2 meetings and we're about to have a third one with the ISB chairs over the last month. They've gone to their examiner pools, and I think for general surgery, for example, we've got over 70 examiners have come forward for November already.
Right.
So
in full PPE.
Whatever PPE is required in the workplace, yeah. I'm not going to put Professor Spence in a bubble.
Great, thanks, John. Look, it's been a fabulous hour. I would love to take this on for another half an hour at least. You've answered 62 questions. There's been over 130 questions asked, and you've answered 62, and the rest I think we've just about covered in answers directly to the attendees. I think that's marvellous. It shows that even the elderly can multitask, and the youngsters have helped out in a big way. So I think it's been a great session. I've really enjoyed it, and so thank you to all of you for giving up your time, and all the attendees for listening. We've had well into the 250s tonight listening on a lovely evening. So I hope you've learned a lot, and I hope we've answered your questions. We are on your side, trainees, and if there are concerns, let us know and we'll try and address them. It's a difficult time, and we're here to try and make it better. So thanks very much, everybody, and have a lovely evening.
Thank you.
Bye.
Bye-bye.